So at the outset, a very good morning to all of you, and I must congratulate the organizers because this is one of those rare conferences which is going prior to the time allotted. Otherwise, we are usually late. So just before I think it is not the time for lunch, so everyone should be a little stimulated to hear the presentations. And I must thank Dr. Smiti and the Department of Psychiatry at Raebareli to have organized this and to have invited me for this presentation. Again, like Professor Anurag said, this is again a disclaimer because the Department of Psychiatry at AIIMS BHU has recently acquired the rTMS. We are just a baby, around 4 to 6 months, and because of certain glitches, technical and red tape, it has only started functioning for the past 3 months, 3 or 3.5 months, and we have now two people who are working. One is on smoking, and the other is one MD psychiatry candidate who has been given. So we don't have that amount of experience or data of literature, as Professor Kar was saying. So we are really enlightened and to hear from him. So I thank all my prior speakers. They have made my work much easier because I'll be skipping through so many slides, but I had to add them because for the need for completion. So I think we'll start it. So this will be the outline of my presentation. Again, the history. So we owe it to David Cohen, who gave us this machine. And then this is in the outline of how history has been there. So we start with Faraday, who gave us the electromagnetism, and then now we have the FDA approval. So these are the various highlights of the timeline through which we are now with the rTMS machine. This is again David Cohen. The introduction to but again we start. So transcranial magnetic stimulation, most of us know and has been presented by my previous speakers. Like I said, my task is much easier now. So this is a longish slide. Suffice it to say here that the rTMS actually stimulates the neurons and turns the synapses. And these may be long-lasting changes because neuroplasticity comes into functioning. Again, this is a simpler version of how rTMS functions, and evoked potential has been explained by my previous speaker, Professor Kar. So this technique is again an outpatient technique, which is simple. The person walks in, has it, and can walk out. So that is precisely the reason why Monday to Friday is actually given, because Saturday, Sunday is non-working days for people abroad. Again, this is the type of IMS, which these are slides basically focused for the residents to make it a little simpler. This is a single pulse TMS, then we have a paired, and then we have a repetitive, which is higher frequencies for cortical excitability, and the lower frequencies for cortical inhibition. So the accessible areas, I just wanted the residents to know what are the DLPFC, the SMA, the SFG, or the TPJ, all these areas they should be aware of. Again, the localization of target has been explained so lucidly by Professor Kar, and these again I will just skip through the slides because the 5 centimeter rule, or the beam F3 system, which is responsible for us locating the target area. And most recently we have the neuronavigation, which is the best way. And about a couple of weeks prior to coming here, we've had our hands on the neuronavigation machine as well. So these are the various types of coil which have again been explained by all the previous speakers, including Dr. Kar and Dr. Smiti. So I won't be going, and these are the common stimulatory packages which are there. Then these have again been explained by my speakers. So the 10 hertz stimulation, or the 1 hertz stimulation, intermittent theta burst, and the continuous theta burst stimulation. All the protocols, etc., have been explained so well and so lucidly by my prior speaker, Professor Kar. So again, indication, these are all repetition slides. So I'll quickly go through all of them. Contraindications again has been, there are only one absolute contraindication, and that is whether we have a metallic hardware in the close vicinity, like a cochlear implant or the internal pulse generator or any other implant. Other very interesting a contraindication, if somebody has a metallic tattoo, so that also has to be kept in mind, because nowadays we have people who come with a lot of tattoos around. Then in rTMS, depression indications, treatment resistance, intolerance to medication, or it can be an adjunctive therapy or the maintenance therapy. Again, the protocols and depression has been so lucidly told by Dr. Kar. The various mechanisms of action which are responsible for the rTMS antidepressant are ranging from the neurotransmitter to the neural circuits to the hippocampal neurogenesis, and also they have a molecular pathway which targets the BDNF. So it has a whole gamut of action responsible for the antidepressant effect, not only the serotonin and the classical neurotransmitters, but it goes on to even the molecular pathways, which actually make it quite an effective tool for therapy in as an antidepressant. So again, this is a continuation of the slides on the antidepressant action, that it enhances the cerebral blood flow, also the transsynaptic global metabolism, and then there are certain connectivity changes which have been touted to be present when rTMS is given. Now, this is a very interesting diagram. Actually, if we look at what we have as symptoms and signs of depression, so we are targeting just a very small area, but the connections are so wide. So we have certain areas which target the psychomotor symptoms, then the cognitive, the emotional, the neurovegetative. So one can argue why a small area. Well, area is an area which has such ramifications and connections to so many multiple areas which are responsible for various other symptoms and signs which do occur in depression. Even if we look at it, there are certain symptoms which are a part of OCD or an anxiety, or we have psychomotor symptoms as a part of schizophrenia, cognitive for dementia. So that is precisely the reason why rTMS can be so good at providing treatment as an adjunctive treatment for various other disorders. So the areas and effects, well, DLPFC, that is the baby, that is such a prime area. It is for addresses the frontal hypoactivity. Then the right DLPFC, as was mentioned by Professor Kar. Actually, Professor Kar has made my work so easy. So thank you for making that. And those are the other areas which are present, and their functioning has been elucidated and highlighted. So these are the treatment protocols. Again, this is a repetition of what has been talked about. So I think I will skip. People who are interested can always take a photograph. Otherwise, it is all there in the journals. Again, like was talked about, these are various protocols which are commonly given. SAINT protocol is one protocol which is now a very favorite protocol. What is concerning is that in West we have this insurance, coverage by insurance. We don't bother about insurance so much, but the Western counterparts, etc., they have a lot of issues with insurance. So which protocols are covered by insurance, that becomes their very primary area of interest. So we have this typical ITBS, intermittent theta burst, which is often covered by insurance. Other parameters can be seen in the slide, but one particular like loophole or a limitation can be coverage by insurance. So they become a lot of experimental rather than being a run-of-the-mill phenomena. These are the certain regulatory guidelines which have been published and which are there available, and these are the Clinical rTMS Society's treatment guidelines. Then this was in Neurophysiology 2020, the International rTMS Consensus guidelines, which was published. So as per these guidelines, and like Professor Ka was saying, even the Indian Journal of Psychiatry recently, 2023, they have published their own guidelines. So I think the residents should go back and read, and all those people who are interested in working should be aware of these guidelines. So side effects, again, this is just a repetition of what has been talked about. Complications, the serious complication is seizure, which is very, very rare, and local pain or tinnitus and hyperacusis can occur, which are all transient. They get over with time. Only seizure is one thing which should be taken care of, and a proper history and a proper filling up of the form, like Dr. Anurag Varma had talked about, can regulate this particular complication. So again, application for TMS, it is a therapeutic tool. It can be a research tool. And neurology is also very excited about this, and they have so many indications for rTMS. And recently, from the Department of Neurology at AIIMS, we had a conference where they had a full session on rTMS in Parkinson's and dementia and in movement disorder. Then Tourette disorder, of course, it is there, and that was a very good session which they had. They had actually done a hands-on training and a demonstration of its effect. So again, neuromodulation and plasticity, as I have talked about in the antidepressant action, this is one of the action which is a longer lasting action. But subsequently in dementia, in elderly especially, neuroplasticity has been shown to be very less effective, because probably it is age related, and the amount of plasticity does not occur at that point in time in the age. So precautions, again, I said, like, this has already been talked about. And determinants of better response, like it was already talked about by Prof. Sakar, from the person related to machine related to illness related, and even at the molecular genetic related. So we have the CC homozygosity and L genotype for transporter gene. And if a good neuronavigation is provided, then that actually predicts a better response. Examples of rTMS devices are just for a theoretical purpose. And the treatment procedure is like a person comes, a full course should be given. That is very, very important. If supposing halfway the treatment is done, like any other treatment, the chances of success are limited. So we should be very careful if we tell the patient that, see, if you have to undergo this treatment, you should take care to take the entire full gamut of treatment rather than dropping in between. If one drops in between, then probably the chances of good efficacy is limited. So who does it? Well, it is a physician who does it, and under the physician's guidance, a technician can be there and takes over. But it is not only a technician's job. So it should be primarily a rTMS physician. So how is it done? Well, individuals are made to sit on a comfortable chair, as was there on the paper, on the flow, and the patient should be awake. The patient is relaxed, and sometimes the people may complain about the ear disturbance, so they can be offered earplugs. Most often our patients do not require earplug, and sometimes they have this sensation. If anybody has that sensation of khatta in that teeth, that kind of sensation is there when electricity passes through. So that kind of a sensation is there. Apart from that, there are no other problems which occur, but this is how the flow of treatment goes, and this is how it is administered. Well, rTMS and medications, do we continue the medications? Well, yes. If the person is stable on medication, it would be advisable to continue medication along with rTMS. And during the process of the course of treatment, if possible, it is advised not to alter or not to change any medications. And sometimes people are required to be stable for 4 weeks on medications prior to starting. But if we say that we are giving it for a treatment resistance, then also if the person is sort of maintaining on the treatment and we want to boost up this particular person for therapy, then also one person needs to be well maintained on medication. We may not be required to taper or stop the medication. That is the point which should be given. rTMS as a research tool, well, it is now, I will just show one slide and one figure from IJP 2023. The amount of publication has gone up by leaps and and bounds regarding rTMS. So we have this baby. It is not a new baby, but this baby is there whom we are sort of nurturing very fast, and probably it will be later on a future recipe for a good recipe for treatment, because in psychiatry we keep on taking something and picking up things which will improve the lot of our patients. Our primary focus is that. So this is our department of psychiatry. Again, in antidepressant response, this again, I review of certain studies. Now, this was a very good study in the Canadian Journal of Psychiatry in 2023 on depression. They did, actually, they divided the studies into 5 categories. One was the first generation. Somebody is very angry. And the second was the second generation. First generation was less than 10 sessions. Second generation studies were for more than 10 sessions. The third generation they had combined like a bilateral rTMS. And then the fourth generation they looked at the meta-analysis. And again, the novelty of studies was the fifth generation. Now, what were the first generation studies the reports were sort of equivocal, not very heartening. But the second generation, again, the results in the high frequency were giving a lot of substantial therapeutic efficacy. And the third generation studies were again, like these were bilateral, sort of experimental studies. And there were a couple of limitations to these studies, like they were not compared with the sham rTMS. So, and they were not conducted for more than 10 days. So there were some substantial limitations to these studies. So also that was not very confirmatory in their result. Meta-analysis, there were 8 meta-analysis that these researchers evaluated, and the analysis of antidepressant effect was mostly on the DLPFC rTMS and high frequency for the more than 2 weeks. Then depression and ECT. This is just a slide for the residents. How ECT differs from rTMS. We can say rTMS also involves a lot of current, magnetic, and then leading to current, and ECT we give direct current. So ECT, there are so many limitations. We have to anesthetize, we have to prepare the patient has post ECT, so many side effects, patients have a lot of stigma, and we need a lot of preparation for an ECT. On the other hand, rTMS is a simpler version, but the response and the range of response with ECT is slightly better than the rTMS. It not very encouraging, but yes, by and by, as rTMS progresses further, I think we will be sort of giving away or getting over with ECT. But ECT is a very good treatment modality. So if somebody is there who has a lot of stigma or a lot of inhibition, one should try and get over it. So now I'll come to the other illnesses which have shown. I was primarily asked to talk about clinical updates, which will come later on. So these are certain very recent studies which have focused on various different disorders in psychiatry. So we have our bread and butter mostly is schizophrenia. So this is psychiatry research 2014, the effect size for alleviating the negative symptoms. Most of the studies which have been done on schizophrenia have found that the negative symptoms, the executive functioning, the working memory and language are the ones which are targeted and which are beneficial more often than the positive symptoms. In the positive symptoms also we have auditory hallucinations, which are more responsive to rTMS than active delusions or any other thought disorder. So this should be kept in mind. We have to choose the patient accordingly if we have to get a good result out of rTMS. In the bipolar affective disorder, there are so many studies. Then there was an RCT which showed that in bipolar, the rTMS is effective in specific phases of the disease. Now, which would be the specific phase? Obviously depression, but there are so many studies which have shown efficacy in mania also. But we can understand the operational procedure for administering rTMS into a manic patient becomes a little difficult. Person has to sit still. How many of our manics do sit still until we sort of sedate them? And then that becomes a sort of a limitation. But nevertheless, there are studies which have shown that results on manic disorders is also good. And the results are still very heterogeneous, and certain protocols which have a homogeneity in their presentation have to be sort of developed. Then again, rTMS is considered a cognitive enhancer, even in healthy subjects. Now, that doesn't mean that all of us start getting an rTMS just to increase our memory, or just prior to the exam, we have this session of rTMS. Now, that is not there because we don't have that much rTMS. Probably one day we might. So Dr. Kar is there. He's an active researcher. So we can hope and put our hopes on him. So again, this was bipolar mania in 2021, as I was talking about. They have shown that their sham, in comparison to sham, the DLPFC was much better. So again, these are very few studies on manic. Most of them are focused on depression and suicide. This was a Journal of Clinical Psychiatry. Then they showed that in subjects who had suicidal ideation, if rTMS was given, the completion of suicide was much less. So this is one very heartening thing, because in suicide we often say that ECT is the emergency treatment for a suicidal ideation or an acute suicidal individual. So OCD, like it was talked about, depression and OCD are two very, very important illness which are now a target of rTMS. In this neuropsychiatric disorder 2018, they said that the FDA cleared a kind of a recipe, like tadka and all that, recipe for OCD. Now, this recipe is that there should be an rTMS device which should be brain-based. There should be an H7 coil, and then the high frequency stimulation more than 20 hertz, and the dorsomedial PFC or ACC should be targeted. Now, this, if all these are combined, it kind of becomes a recipe for OCD treatment. Again, in Frontiers, we found that elderly showed increase in symptom severity, not stability, after rTMS. And probably this was because of their age and the brain, the limitation of brain plasticity. Again, this study in biological psychiatry showed that there was a greater improvement if there was comorbid depression. And this is again self-explanatory, because we are targeting so much on depression. So OCD with depression would perform better with rTMS. Now, these are the clinical predictors of who responds to OCD. If a person has OCD, who are the people who would respond much better? So they found that obsessional severity, resistance, disturbance, and interference due to obsessions are resistant against compulsions were the items which predicted a better response on the Y-box. So the choice of patients can be done and limited. Dementia. Now, there are, starting from certain case reports to some RCTs, there are multiple, the research is, the literature is replete with a lot of studies. Now, one study in, like this was showed us stronger DMN connectivity at baseline. This Alzheimer's Research and Therapeutics in 2025. This was a 52-week. They showed a better connectivity in the percutaneous. So again, one study, this was done in a single memory clinic at Korea. Now, this is something which they have done, which was very interesting. That what they did is that they did the hippocampal network was targeted by rTMS. or a sham stimulation. And the fMRI connectivity analysis revealed that rTMS increased the functional connectivity between the hippocampus and the percuneus. Now, this is a single study from a single clinic in Korea, but it has to be replicated further. But this was something which was very, very important, very, very interesting. And they also showed it that there was an improvement in the ADAS-Cog, that is the scale which is done to measure as like dementia. This has two components, the ADAS-Cog and the ADL, that is activities of daily living. So they showed that there was a substantial improvement in the cognition along with the increase in the connectivity at the hippocampus. Other psychiatric disorders like sleep modulation, there have been multiple studies, and this facilitates plasticity, learning, subsequently improving the effectiveness of rTMS in the sleep modulation. In catatonia, there are a couple of case reports which have shown that rTMS can be very effective in catatonia. But this amount of evidence is actually limited to case studies. No like open label or double blind or RCT, so those are lacking. Again, in insomnia and MCI, again there are in REM and non-REM, there are stages, techniques, and neuromodulation where the patients are shown to show some improvement. In addiction, as was talked about, addiction is the new baby, which rTMS, especially nicotine. We also have one study which is ongoing for nicotine, and this has started. This study, especially the Annals of New York Academy of Science, they had taken 19 human studies, out of which they involved 9 studies for tobacco, 6 for alcohol, 3 cocaine, and 1 methamphetamine. Mostly all these individuals were shown to have a good response to rTMS, but they concluded that this is still in the experimental phase. So again, this study was stimulation, a promising treatment for craving and stimulant drugs. And this again was a meta-analysis which showed that there are different combinations of target, and the frequency stimulation is also different. Dr. Carr had already elucidated that there are protocols which have to be designed. So this was also a conclusion of these studies. I think this, where is that? So this is rTMS in special populations, especially in adolescents and children. Now, still we do not have an FDA approval, but there are so many studies which have been done. And this is a Journal of Affective Disorder, wherein they showed that the adolescents respond to depression much more than any other illnesses. Again, this was these are the various studies which were done. Some were done in headache, a depression, 3 of them. Then there was an epilepsia partialis, and then again there was this study on spasticity. So the conclusion would be that rTMS is a promising treatment, but it has to good profile of efficacy and safety has to be established before we start full-blown treatment of adolescent and children. Then there are rTMS studies. Well, the person who's quoted is sitting here. So this is the figure that I was talking about. You can see how many studies are being conducted now. Over the time, they have gone on increasing. So this is one figure which talks about how much we have been taken over by rTMS, and we are into it with a lot of fervor and lot of zest. So people who have rTMS should actively start researching in this field. And we have also taken it, and recently when we started, we now have 2 people doing work on this. So probably next couple of years, we might have BHU also coming with certain publications. So these are now, let's talk about innovation. First and foremost is innovation in coil, as was talked about. We have this coil, they have come over in so many years. There are certain benefits, but there are also limitations. So if we have a TH coil, well, this offers a good deep penetration and a strong magnetic field which can penetrate deeper. But then there are limitations that it needs some more optimization, and it is a little complex. Then there is again UBC, that is precision is reduced, stimulation of the volume is not so much. Again, this is complex and needs further optimization, because we are still in the progress phase and we are focusing on it. So we have a lot of ifs and buts, yes and no, and we need a lot of operationalization and optimization for things to be really in a black and white shape. Then we have this HDC coil. This is safe and efficient, but it doesn't have a very good advantage over the classical figure of 8. Again, this again gives a good improved focality, but again the design is complex. Circular coil gives a consistent magnetic field, but needs a lot of comparative data. Again, multi-locus is faster in optimization and precise control. But then there are manufacturing challenges, because when we do an experiment, we should also know that a machine is built. The building a machine also is itself a complex procedure, which involves so many different things. Then we have AI everywhere, from DeepSeek to Grok, which is creating a lot of havoc. So this is an AI age, and AI is also used in rTMS. So how AI is used? There are so many algorithms which can be used to analyze the extensive data set. Supposing we do come up with a whole lot of experiment, we have so much of data. To analyze that data itself, if AI is there, it becomes very easy, and it also becomes fast. So we have a conclusion at our hand in a immediate or in a very shorter span of time. This also can personalize therapy, and by using the AI and the data set, we can come up with a personalized data for an individual. So we can offer a recipe to an individual. So yes, Mr. X walks in, Mr. X has this is symptoms. So these are the investigations. We put it in the AI tells us, okay, fine, Mr. X should receive this amount of therapy by the rTMS. So the day will come when we will have AI at our hands, and we can offer treatment which can be personalized. Then research and collaboration can be helped. Predictive analysis, that this particular person gets this, so the prediction of chances of improvement, how much is it, that can be predicted with some amount of precision. Then this can improve the integration of rTMS with neuroimaging. Now we have this navigation and various methods where fMRI and MRI are incorporated, and rTMS, so that we come up with a better understanding. And then MRI scans can be optimized, and coil placements can be optimized and focused and given with a lot of precision. Again, this is another innovation where we have a wearable device of rTMS, like we have Holter. We put it in the pocket and move around and do our work, and the entire recording is there. So similarly, the individual can wear like a backpack, and then the rTMS is given like throughout the time, or it becomes very easy. The person doesn't need to come to the clinic. They can have this kind of a Holter monitoring kind of a portable device, which can be worn for rTMS. Then again, there are innovations, there are limitations regarding the rTMS device. The innovation and the limitation. When improved power of circuit comes, there is an increased complexity, cost, and also some amount of heat generation. Then these integration can cause a lot of higher complexity, cause again maintenance, or becomes tricky. Open access TMS database can be incomplete, it can be outdated, and there can be potential biases. Efficient cooling, AI for operationalization and modular designs. Again, balancing innovation with a lot of practicality. We just cannot be very utopian in our experience or in our outlook. We just cannot have the ideal setting, because nothing is ideal. So even a machine is not ideal. Machine comes with a lot of its limitations. So that has to be taken care of. And when we talk about data set enhancement, then implementation, it becomes complex, and there is always a need for standardization. Well, future direction, the market growth of rTMS is just boundless, and so it is a good market value for people who are manufacturing and people who are doing. So device has to be simplified, it has to be cool, and the costs have to be cut down to be accessible to others. Right now in AIIMS BHU, we do not take any charges, but the day will come when we start charging. So that again, charges are not so accessible to people, especially people who are below the poverty line or who have this Ayushman Bharat, because this particular thing doesn't come in that gamut. The coil technology, again, new coil designs and ties with neuroimagings and brain computer interfaces have to be real time. Then imaging and neurofeedback, incorporating the MRI, fMRI, and the real time neurofeedback are other key points which can be effective in the future. Future directions, we can incorporate other methods along with the rTMS, like multimodal applications. rTMS with EG, rTMS with you name it and you have it, fMRI, FNIRS, combination with PET, DTI, then we can have improving precision, starting from genetics to the functioning of the machine, like rTMS brain network, neural oscillations, open loop and closed loop, precision with genetics, like we have this neurogenomics. You have this genetic makeup, come to the person, come to the desk, and you take medication as per your genetic requirements. So similarly, the day will come when we have rTMS explained on the basis of an individual's genetics, like we've talked about val homozygosity and all that. A precision with neuroimaging. So this is again a summary of innovations in rTMS, and this is from 2019 to 2024, and then their limitations. Neuronavigation for precise coil positioning, this is complex, needs training, because we recently had this particular person come to us for training us to locate the DLPFC. Although it may appear simple, but we really need to at least undergo the training once or twice. Then advanced software for precise stimulation, again standardization and reliability issues. Well, this is not to dishearten, it is to be in the real time. When we talk about some innovation, we should also be aware of the limitations of that innovation, so that we are attuned and adept to get over it. So we train ourselves, we optimize the machine, do something to get over those limitations. This is not puncturing the enthusiasm, but making it a real-time enthusiasm. User-friendly touch screen interfaces, cyber security is a huge concern. We live today in the times of cyber security and cyber fraud. Tools for stimulating and simulating and visualizing target areas come with a lot of cost. The real-time adjustments, again, are complex, specialized. We have recently, there was one proposal where this was an old study by chanting Om. One of our colleagues is wanting to do that, but this was done, I think, in 2011 in Niman, that they had chanted Om and they had shown some amount of activity in the insula. And one of our thesis is actually was presented, but of course we have this neurology department where they are not ready for an fMRI, but let's see if we talk to them and we might come up with that. So AI driven real-time treatment adjustments, they increase complexity. Again, predictive analytics, data quality, bias risk, MRI accuracy and integration costs are all limitation factors. Well, to conclude, rTMS is here to stay, and this is very effective in depression and with various other modalities. So this is a concluding slide. These are the references. Thank you.